To conjugated bilirubin, it is a direct hyperbilirubinemia. It is seen mainly in biliary tract obstruction, like in gallstones, cholangiocarcinoma, pancreatic or liver cancer. So, what you need to understand is conjugated hyperbilirubinemia will be after passing the liver, because in liver the bile will get conjugated. So, it will be after passing the liver. So, there may be gallstones, cholangiocarcinoma, pancreatic or liver cancer, biliary tract disease like primary sclerosing cholangitis, primary biliary cholangitis, and all these conditions. Excretion defect in the case of Dubin Johnson syndrome and Rotor syndrome. Next, unconjugated will be high in hemolytic benign neonates, Crigler-Najjar Gilbert syndrome. Beta glucuronidase is a lysosomal enzyme that usually deconjugates the direct bilirubin. It is also found in intestinal breast border and breast milk, sometimes leading to neonatal unconjugated hyperbilirubemia, and it will lead to pigment stone formation. Remember, pigment stones are formed because of unconjugated hyperbilirubin. Mixed hyperbilirubinemia is where both direct and indirect hyperbilirubinemia, and this is leading to hepatitis and cirrhosis. Next is benign neonatal hyperbilirubinemia. Actually, it is seen in neonates because in the actually it is called as physiological neonatal jaundice, because mild unconjugated hyperbilirubinemia is seen when there is more RBC turnover, because in fetal RBC lifespan is very low, and immature newborn liver because there is decreased UDP glucuronidase transferase, and also sterile newborn gut, there is decreased conversion to urobilinogen. So that is the reason why there's increased deconjugation by intestinal beta glucuronidase and increased enterohepatic circulation. Actually, breast milk jaundice is where increased beta glucuronidase in breast milk. So that will lead to increased deconjugation and increased enterohepatic circulation. Breastfeeding failure jaundice is insufficient breast milk intake, so decreased bilirubin elimination in stool, that is leading to increased enterohepatic circulation. So severe cases may lead to kernicterus, that is a deposition of unconjugated lipid soluble bilirubin in brain and also in basal ganglia. So treatment is phototherapy, that is non-UV, and also isomerize unconjugated bilirubin to water soluble form. Biliary atresia, actually it is the most common reason for pediatric liver transplantation, because there is obstruction of bile ducts and that is leading to cholestasis. And when there is cholestasis in newborn, it will lead to jaundice because of increase on conjugated bilirubin. After 2 weeks of life, there will be darkening urine and also alcoholic stools, hepatomegaly. Next, coming to hereditary hyperbilirubinias, all those are autosomal recessives. Actually, in Gilbert syndrome, there is decreased UDP transferase conjugation. So you can understand here, because there is decreased this enzyme, that will lead to increase in unconjugated bilirubin. Next is Crigler-Najjar. Here also there is absent UDP glucuronidase transferase. So because of that, there will be jaundice, kernicterus. Here also unconjugated bilirubin will be increasing, and that will go into brain also. That is kernicterus. Okay, if it goes into brain, treatment is plasmapheresis phototherapy, that does not conjugate UCP but does increase polarity and increase water solubility to allow excretion. Actually, we do phototherapy and plasmapheresis for that process. A liver transplant is curative because in this liver there is no UDP glucuronidase transferase. Okay, type 2 is less severe and responds to phenobarbital, which increase liver enzyme synthesis. Next, Dubin Johnson syndrome. Here, conjugated hyperbilirubinemia is mainly due to defective liver excretion. Actually, liver is not able to excrete here, so there will be increased conjugated hyperbilirubinemia. It is causing dark liver due to impaired excretion of epinephrine metabolites. And next, coming to Rotor syndrome, it is phenotypically similar to Dubin Johnson but milder without black liver. So in Dubin Johnson, dark liver; Rotor syndrome, no dark liver. Okay, it is due to impaired hepatic storage of conjugated bilirubin. Going to Wilson disease. Wilson disease is accumulation of copper. So mainly it is due to autosomal recessive mutation in transporting ATPase, copper transporting ATPase. Because of this problem, there is decreased copper incorporation into apoceruloplasmin and excretion into bile. So that is leading to decreased ceruloplasmin. Actually, ceruloplasmin is required for copper transport. So if ceruloplasmin is decreased, then copper cannot transport, and that is leading to accumulation, especially in liver and brain. corneas, kidneys, and that is leading to urine copper. So it is presenting before age 40 with liver disease like hepatitis, acute liver failure, cirrhosis, and neurological diseases like dysarthria, dystonia, tremor, Parkinson's, psychiatric disease. Clear facial rings are seen on slit lamp examination. Deposits are also present in descended membrane of cornea. Hemolytic anemia, like Coombs negative hemolytic anemia, is present, and renal disease example Fanconi syndrome. So treatment is chelation with penicillamine or triantarin, and also oral zinc. Liver transplant can be done in acute renal failure. Next, coming to hemochromatosis, it is because of accumulation of iron. So actually non-heme Fe plus 3 is present normally. By vitamin C it is converted into Fe plus 2. Only Fe plus 2 can be absorbed in our duodenum, and this is because of mutation C282Y mutation, C282Y or H6D3D mutation. It is also autosomal recessive. Here the mutation is in HFE gene, and which is on chromosome 6. It will lead to abnormal hepcidin production. So that will lead to increased intestinal iron absorption, and iron load can also be secondary to chronic transfusion therapy. Like in thalassemia patients, we give transfusion. So in that also it will lead, and iron accumulates in liver, pancreas, skin, heart, pituitary, joints. Hemosiderin can be identified on liver MRI or biopsy with Prussian blue stain, you can see. So it presents after 40 when total body iron is greater than 20, and iron is lost through menstruation in females. So in females, this will not be that much high, it will present later in their life. Classical triad of cirrhosis, diabetes, skin pigmentation, bronze diabetes causes restrictive cardiomyopathy or dilated cardiomyopathy. Hypogonadism, atrophy because of calcium pyrophosphate deposition, especially in metacarpophalangeal joints. And hepatic cellular carcinoma is common cause of that. Treatment is repeated phlebotomy, iron chelation with deferoxamine, deferripinon. Here FE is present in everything because it's F iron chelation. Especially it's done in anemia patients. Okay, so increase iron, increase ferritin, decrease transferrin because already there's lot of iron. Increase saturation. Diagnosis Prussian blue stain. Now coming to biliary tract disorders, actually here the problem is in the biliary tract. So you can easily guess that there will be increase in conjugated bilirubin because it is after the liver. So it will present with jaundice, dark urine. Dark urine because it is conjugated, so it can pass through urine. But pale stools because it is conjugated. And it is light colored stool, hepatosplenomegaly, typically with cholestatic pattern of LFTs. That is increased conjugated bilirubin, increase cholesterol, increase ALP, and increase GGT. So it is divided into primary sclerosing cholangitis, primary biliary cholangitis, secondary biliary cirrhosis. So primary sclerosing cholangitis is nothing but there is a fibrosis of the biliary tract. You can understand if there is fibrosis of biliary tract, it will back up. That will lead to elevated liver enzymes. Sometimes it also lead to cirrhosis or fibrosis of bile duct. You can see onion skin bile duct fibrosis, stricture and dilation, bleeding of intra-extrahepatic biliary duct. You can see it on ERCP and MRCP. So classically in middle-aged male will ulcerative colitis. So it is associated with ulcerative colitis. There is right upper quadrant pain, fatigue, jaundice, increased alk phosphate. Always remember when the biliary tract is involved, then there is increased alk phosphate, increased conjugated bilirubin. Diagnosis is cholangiogram associated with ulcerative colitis, MPO, ANCA, PANCA. Increased IgM can lead to secondary biliary cirrhosis, increased risk of cholangiocarcinoma, gallbladder cancer. Next, primary biliary cholangitis is causing cirrhosis to the liver. It is an autoimmune reaction mainly of lymphocyte infiltrate, granulomas, destruction of lobular bile duct by T cells, classically seen in middle-aged female. So that is in male, this is in female. But having fatigue, pruritus, most common initial symptoms, that is because of increase in bile acids, they are accumulating in the skin and sclerum. Especially you'll get itching at the late night because of increased bile acids. Next, coming to anti-mitochondrial antibodies present, increased IgM associated with other autoimmune conditions like Hashimoto thyroiditis, rheumatoid arthritis, celiac disease. Here also increased alk phosphate, increased lipids, especially xanthoma. Diagnosis is liver biopsy, which is a gold standard. It is most common associated with Sjorgen syndrome. Treatment is uroshiodol. Next, coming to secondary biliary cirrhosis. It is extrahepatic biliary obstruction. It is outside the liver, so there will be increased pressure in intrahepatic ducts, because even though obstruction is outside, it will back up, right? So for example, here is the liver, so if the biliary duct is blocked, it will back up and go up, so that will lead to injury and fibrosis of the bile, of the intrahepatic ducts. That will lead to bile stasis. So patients with known obstructive lesions like gallstones, biliary strictures, pancreatic carcinoma present with this, it may be complicated by acute cholangitis. So next, coming to biliary atresia, that is complete absence of biliary tree. It is seen in neonates, so that will lead to jaundice, but this will be conjugated dark urine, so it will cause dark urine, pale stools, okay. And also alcoholics may have same thing. Treatment is Kasai projection, that is a create a channel from the small intestine. As there is no channel, we will create the channel, okay. Biliary cirrhosis is liver damage due to bile duct damage, that's it. As a bile duct is damaged, no liver is damaged. Next is a cholangiocarcinoma. Actually, it's a very rare cancer of bile duct epithelium. Symptoms are due to bile duct obstruction, cause chronic biliary inflammation. Primary sclerosing cholangitis or clonangitis sinuses can also cause this. Cholelithiasis and related pathologies. Actually, cholelithiasis are the stones which are present in the gallbladder. So actually, the causes of gallstones are increase in cholesterol is the one thing, and another one is increase in bilirubin, or they may be decreased bile salts or gallbladder stasis cause a sludge or stones. So actually, you find two types of stones. One is a cholesterol stone, one is a pigment stone. So cholesterol stone is formed because of, especially in females, because of some age related conditions, obesity, genetics, decreased cholesterol 7 alpha hydroxylase. All this will precipitate to increase cholesterol and decrease bile salts. In Crohn's disease also there will be inflammation of ileum, so there will be decrease of bile salt and gallbladder stasis. All these conditions will lead to supersaturation of bile with cholesterol. That will lead to formation of cholesterol stones. Cholesterol stones will be yellow as usual, you expected, because cholesterol is present. Chronic hemolysis will lead to biliary tract infection. That will lead to increased unconjugated bilirubin. That is leading to gallbladder stasis or gallbladder stasis, okay. That will lead to supersaturation of bile with calcium bilirubinate, and that will form pigment stones. They are like somewhat black or brownish color, so these are the pigment stones. So two types of stones are formed by formed in the biliary tract. Remember that cholesterol stones are radiolucent and opaque due to calcifications. 80% of stones are associated mainly with obesity, Crohn's disease, estrogen therapy, multiparity, rapid weight loss, medications like fibrates, and mainly it's seen in white and Native American population. Also, loss of bile salts, increased lipid will lead to this. Even liver cirrhosis lead to decreased bile salts, so that will also lead to increased cholesterol stones. Next, pigment stones are black, radiopaque. They're calcium bilirubinate. They're brown or radiolucent, associated with Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced age, biliary infection, total parenteral nutrition, because total parenteral nutrition will increase unconjugated bilirubin. Most common complication is cholecystitis, which can cause acute pancreatitis and acute cholangitis, because it is near, I think, major duodenal papilla or head of pancreas. So it is leading to both things, acute pancreatitis, acute cholangitis. So treatment is just surgery or urosodecolic acid, which decrease cholesterol secretion to the bile. Okay. Diagnosis with ultrasound. Treat with elective cholecystectomy if symptomatic. Risk factors are 5F: female, fat, fertile, 40, fair. So I remember a 50-year fertile, 40, a 40 a 40-year fertile, fat, fair female, okay. She have higher risk to get the stones. Next, let us understand biliary colic. Actually, it's a pain whenever you eat fatty food. Why? Because something is blocking this gallbladder. For example, the stone is here, it is blocking. So whenever you eat fatty food, actually cholecystokinin will release. It will lead to contraction. But there is stone, so you'll get pain, especially in right upper quadrant pain, and that will also go to your shoulder for 30 minutes on right side of the shoulder. Next, cholelithiasis. Actually, it's a presence of gallstone in common bile duct. For example, here like this. Okay, if it is present in common bile duct, it will lead to elevated alkaline phosphate (GGT), direct bilirubin, AST, and ALT. Right. Next, coming to cholecystitis, is divided into two types. a calculus and acalculus. Calculus is most common type, that is due to gallstone impaction in cystic duct, same like here. So it will result in inflammation and gallbladder thickening, and can produce secondary infection. Because of secondary infection, so if infection increase WBC. Next, coming to acalculous cholecystitis due to gallbladder stasis. Gallbladder only, it is undergoing slow movement. So hypoperfusion or infection seen in critically ill patients. There is a Murphy sign, that is if you are palpating on the right upper quadrant, then you're getting suddenly you're stopping the inspiration because of pain. So that pain will radiate to right shoulder due to irritation of phrenic nerve, and that will lead to increase ALP in bile duct. And diagnosis with ultrasound or HIDA scan. If you do HIDA scan, actually we try to see the gallbladder, but if you are unable to see the gallbladder, then you can say it is blocked by a stone. Okay. Next, coming to gallstone ileus. Actually, there is a fistula formation between the small intestine. For example, if this is a small intestine, between the small intestine and gallbladder, there is a fistula. So what happens, the stone will enter directly into the GI system, and it will obstruct especially at ileocecal valve, that is the narrowest point. So we can see air in the biliary tree. Why? Because that why you see air in the biliary tree? Because the stones are coming here into the GI system. So air in the biliary tree is called pneumobilia. And there is a regular triad, that is radiological finding of pneumobilia, small bowel obstruction, gallstone, usually in iliac fossa. Okay, small bowel obstruction, gallstone in iliac fossa. Next, now let us understand porcelain gallbladder. Actually, it's a calcification of gallbladder because of chronic cholecystitis. Incidentally, it is found. Treatment is prophylactic cholecystectomy, because it will lead to increased risk of adenocarcinoma. Okay, there is also AIDS cholangiopathy, that is chronic HIV can lead to this problem, or cryptosporidium is most common. Cytomegalovirus, stricture of biliary tract, and ERCP is also giving imaging and also therapy. Gallstone pancreatitis is obstruction of common bile duct by stone, and that will lead to acute pancreatitis. Okay, acute cholangitis is called ascending cholangitis because of infection of biliary tree. It is due to obstruction. Because of obstruction, either by stone or anything, that will lead to stasis, right? And that will lead to bacteria overgrowth. Actually, there are two triads very important: Charcot triad, Reynolds pentad. Charcot triad includes jaundice, fever, right upper quadrant pain. Reynolds pentad is Charcot triad plus altered mental status and shock. Shock is hypertension, so that will lead to increased WBC, increased alk phosphate, increased conjugated bilirubin. Okay, E. coli, Klebsiella, chlorenchus sinus is a Chinese liver fluke. Can cause peripheral eosinophilia. Treatment is antibiotics, biliary drainage. Now coming to acute pancreatitis, it is because of auto-digestion of pancreas by its own enzyme, you can see here, and it may also form a pseudocyst. And this is because of the conditions, like you can remember it: I get smashed, I is idiopathic, G is gallstones, C is ethanol. Gallstones is most common. Okay, T is trauma, children pressed by seat belts. S is steroids, M is mumps, A is autoimmune disease like IgG4 positive, and S is scorpion string. H is hypercalcemia or hypertriglyceridemia, ERCP, drugs. So all these are causing acute pancreatitis. It also causes pseudocyst. Cullen sign, Gray Turner sign is positive. Increased alk phosphate, increased conjugated bilirubin, increased WBC. Okay. Next, chronic pancreatitis. You can see it's a calcified, atrophied, chronic inflammation of pancreas. Major risk factor is alcohol in adults, cystic fibrosis in children. This may also lead to pancreatic insufficiency and pseudocysts. It's typically when less than 10% pancreatic function manifests with steatorrhea, fat soluble vitamin deficiency, and diabetes mellitus. Amylase and lipase may or may not be elevated, always elevated in acute pancreatitis. Very important, acute pancreatitis, AST, ALT are always elevated. Uh, yeah, sorry, amylase and lipase are elevated. Okay, abdominal pain, increase after eating. Okay, and lead to splenic vein thrombosis or pancreatic insufficiency. Splenic vein thrombosis is enlarged spleen, and it causes gastric varices. Complications of acute pancreatitis: DIC, prolonged PTT, thrombocytopenia, vascular occlusion, ARDS, that is fluid into the interstitium, pancreatic abscess by E. coli, 10 days after infection of pseudocyst, fat necrosis, fat around pancreas, lead to hypocalcemia, hypomagnesemia, and fatty acids plus calcium cause saponification. Final topic is pancreatic adenocarcinoma. It's very aggressive tumor arising from pancreatic ducts, and that is leading to disorganized glandular structure with cellular infiltration, which you can see here. Okay, and it is often metastatic at presentation. Average survival is 1 year. Tumors are most common in pancreatic head, you can see. So that is leading to obstructive jaundice, you can understand. This is associated with CA19-9 tumor marker, also CEA. And the risk factors are tobacco smoking, that is the strongest risk factor, and chronic pancreatitis, especially greater than 20 years, diabetes. The painless jaundice is causing dark urine, clay stools, steatorrhea. Node positive survival 10%, node negative survival 25%. Age greater than 50 years. Often present with abdominal pain radiating to back. Weight loss due to malabsorption. Migratory thrombophlebitis causing redness, tenderness on palpitation on extremities. This is called Trousseau syndrome, that is hypercoagulable state. Obstructive jaundice with palpable non-tender gallbladder. This is called Courvoisier sign. There are BRCA2 mutations in SNK genes, CA19-9 tumor marker, CEA poor sensitivity. Treatment: Whipple procedure, chemo, radio, surgery, pancreatic duodenectomy. ERAS gene, chromosome 12p, mute frequency, mutated gene, also part of colon cancer. SMAD4 gene, chromosome 18q, tumor suppressor gene, inactivated in 60% of pancreatic cancer. By this, we completed GIT. Actually, it's a very huge chapter. Next, we'll start with endocrine and end with cardiac. And I think in whole first aid only 15 chapters, so we can cover them.